Will they be able to see my slides where you are? Okay. But will that be an actual video of that?
Good afternoon. This is Maya with TMC for Seniors. I have Dr. David Teeple here with me today. Dr. Teeple is the director of our TMC stroke program. He is also a neurohospitalist with Tucson Medical Center, and he also works for the Center for Neurosciences. I know you have quite the list going on, Dr. Teeple. So I want to welcome you here today. We always love having you here to discuss everything about stroke. And I'm going to go ahead. I have your slides up on the screen, so we can all see your slides as you go through those. And I will go ahead and let you get started.
Okie doke. Thank you very much for having me. And I'm thrilled to be here. I'm thrilled to have a live audience, at least to some degree, because talking to a computer the whole time is the pits. And so I'm grateful to be talking about something that I'm very passionate about, which is stroke. And to that end, when I'm passionate about something, I tend to talk fast and blab like crazy. So if I say something that you have questions about, feel free to kind of try to interrupt me and ask me to repeat it or tell me to slow down if I go too fast. And that being said, let's just jump right in. And so my goals here are really to talk about what a stroke is. I think it's interesting that I find that everybody gets confused on what a stroke is. And so reviewing the sort of basics of that, and then talking about the signs and symptoms and what to do if you have the symptoms of a stroke. So first question is, what exactly is a stroke? And again, it's confusing. And I think one of the more common things that I see patients get confused about is differentiating between a stroke and a heart attack, first of all, right? And so a heart attack is a blockage in the blood vessels of the heart, and the heart doesn't get oxygen, and part of the heart muscle gets damaged or dies. But a stroke is actually having to do, of course, with the brain. And interestingly, and part of what makes it so confusing, I think, is that really a stroke encompasses three things that we treat as neurologists. The first one is what we call an ischemic stroke. And this is far and away the most common type of stroke that we see. And so with an ischemic stroke, what you get here is you get a blood clot that blocks an artery in the brain. So you can see right there, right? There's that blocked artery inside the brain, and there's no flow then after this spot. So everywhere that this artery supplies suddenly gets deprived of oxygen, right? So that whole area isn't right. And what happens with an ischemic stroke is you're on a timer. Those brain cells need oxygen to live. They need glucose to survive. And if there's no blood flow bringing a fresh supply of oxygen and glucose, those cells have a limited lifespan before they start to go. They start to die. And so when the symptoms, interestingly, and one thing I actually didn't put in a slide is the difference between a stroke and a TIA. So a TIA stands for a transient ischemic attack, and they're very closely related to an ischemic stroke, right? So the idea is this blockage hits, that part of the brain stops working, but before there's permanent damage, magically, somehow, that clot dissipates and flow is restored and things come back online. That's a TIA. And that's usually a big red flag for something's going on. You need to get checked out for what's going on, versus a stroke where that clot's there long enough that there is actually irreversible damage to part of the brain. Even if the symptoms completely resolve, we can see that damage often on an MRI. So this is an ischemic stroke, the most common type. The second type of stroke that we see is what's called an intracerebral hemorrhage. And so exactly what it sounds like. And that's where an artery in the brain ruptures. And you can see here, I think I have a nice big yellow line. Yep. So what you have here you have these big, huge pipes that come up into the brain, right? The carotid artery is coming up into the brain, and it splits into other big pipes. But off of these big pipes come these little feathery vessels. They're very small, and they're very fragile. And you can see them right here for those of you online. These little guys here. Those are these little friable vessels, and they don't like male gender. They don't like being over the age of 50, and they hate high blood pressure. And with the high pressure, those big pipes handle it. Those little friable vessels, they don't, and they scar, and then they weaken, and then they rupture. And they rupture into the brain substance, which is what you see with this area here. And so this is the ruptured artery. These happen in very specific areas of the brain, always. So this area that you see there, that's called the basal ganglia. They can happen in the base of the brain and in the brainstem. And so typically you show a neurologist or a neurosurgeon a hemorrhage, you can tell in 5 seconds that's from high blood pressure, which is really the major cause for these types of strokes. The last type of stroke, no doggone it, the last type of stroke is behind this picture, and it's a subarachnoid hemorrhage, okay? Subarachnoid hemorrhages are when an aneurysm, which is a ballooning out of a blood vessel, an aneurysm ruptures around the brain. So your blood vessels actually live around the outside of the brain, and so when these things rupture here, the blood circulates out here in what's called the subarachnoid space, the space around the outside of the brain. And so because we're not very creative, the blood in the subarachnoid space is a subarachnoid hemorrhage. And these are the types of strokes that come on with a sudden headache. Boom, like someone, I had a patient once describe it as someone came behind me, doc. It felt like someone came behind me with a baseball bat and just whacked me on the back of the head. It's that sudden onset, worst headache you could possibly imagine. And so these are actually very dangerous types of strokes. The highest mortality of all strokes are the subarachnoid hemorrhages. But as you can see on this next slide, subarachnoid hemorrhage is actually, so this pie graph is looking at strokes, 800,000 strokes a year, okay? But if you look at what causes strokes, ischemic strokes, that first type of stroke is far and away the most common type of stroke that we see. Far and away, essentially 90% of all strokes that we see. And then 10% are the intracerebral hemorrhages. And we've actually been seeing that percentage get less and less. And that percentage has been getting less and less essentially because of better blood pressure control. And as people's blood pressure control and the public's blood pressure control gets better and better, the rate of intracerebral hemorrhages go down. And then 3%, a tiny percent of strokes are subarachnoid hemorrhage. So as much as that's one that we are scared to death of, me included, that is far and away the least common type of stroke to have. So what are the signs and symptoms of stroke? And I guess before we talk about the signs and symptoms, I think it's worth it to talk a little bit about neuroanatomy. So to understand why are we thinking about these signs and symptoms and why these specific things? Plus just neuroanatomy is cool. So the first slide I have here is just to remind you how complex the brain is. That's what I love about neurology and neuroscience. It's also among the more frustrating things I have to deal with every day is recognizing how little we understand. And this is I think this beautiful picture. This is a type of MRI called diffusion tensor imaging. And what it shows, right, and I don't know how well you can see it, but these beautiful, tiny little lines, these are the pathways inside your brain. These are pathways of different neurons, and there are essentially 100 billion neurons in your brain, and we're talking hundreds and hundreds of billions of pathways. And so our brain is extraordinarily complex, which makes sometimes, knowing what's going on and what caused what symptoms sometimes impossible to be perfect about. Now, when we talk about the brain, this is some random guy's head. And if we remove his head and look at his brain, that's what it looks like, okay? And so your eyeballs would be right here. Nose would be down here. And this is your brain as if you're looking, towards the pink front side. And so let's talk a little bit about what do the different parts of the brain do. So the frontal lobe. The frontal lobe, it's interesting. If you were to actually see, if I could hold the brain up and show you, the frontal lobe actually, and no picture ever does it justice. Honestly, the frontal lobe feels like it goes back like that far. It's enormous. It is one of the biggest parts, if not the biggest part of what makes us human. It's where your personality is, your judgment, your conscience. There's so much about your frontal lobe that essentially affects how your personality is. You guys have heard of the story of Phineas Gage. It's a famous actually story of this guy. He was a miner. I think he was mining. And back in the 1800s, the way that they would sort of blast to get at things, and maybe he wasn't a miner, but they would blast rock. I think it was train tracks they were trying to get through, and they were trying to blast through the mountains. And they would drill a hole in the ground and then essentially put a piece of dynamite with a giant stake. And he had the misfortune of looking over one of those when it went off, and it went right through his face. It actually went up through his right below his eye and through his frontal lobe. And the guy miraculously survived. But it's famous because after he survived, he went from being this great employee, super nice guy. He was always on time. He was the guy you could depend on, to becoming foul-mouthed, always late for work, alcoholic, no self-control. And it was all about the destruction of his frontal lobe and what happened. And actually, you can see his skull. His skull's on display at Harvard Medical School. You can Google his picture. It's pretty cool. And the same thing goes for lobotomies, right? They would do lobotomies for psychiatric disease, for many, many times horrible reasons. But you would take out parts of the frontal lobe, and suddenly people wouldn't care anymore. They wouldn't do anything. They just sort of become what they would call abulic. They just don't have any interest in interacting with the world. They're not causing any problems, which is why they would do it, and why we don't do it today. So, personality, frontal lobe. In the back of the frontal lobe, you have your motor strip. Okay, so you actually have motor function of your entire body mapped out, and we'll talk about that a little bit later. In the back of the frontal lobe, and then right next to that, interestingly, you've got this sensory. You have a sensory map of your body right back here. The parietal lobe is involved in sensory integration, and it's interesting. If you knock out part of the parietal lobe, what you can do is you'll get something called neglect. And neglect is an interesting animal, right? You ignore, it's there, but you just forget about half the world. And so the classic story is the story of the guy who has a stroke of his parietal lobe, and he's in the hospital, and the nurses keep finding him on the floor. And they say, "What? Why? What's going on?" And he's like, "I found some guy in the bed with me, and I fell out of bed." And they finally catch him one day, and he sees his own leg, doesn't recognize it, and swings it over the side of the bed and falls out. And I mean, I've seen it. People who don't recognize their own hand, alien hand syndrome. They don't believe it's theirs. Whose hand is this? I don't know. I think it's your hand. Nope. Here's my hand. Whose hand is this? I don't know. It's not mine. And that's profound neglect. So I don't know if you've ever been to the doctor's office, and one of the things that they'll have you do sometimes is draw a clock and put the numbers on the clock. And one of the things we're looking for is actually subtle neglect there, because people can sometimes draw half the clock or they neglect part of the clock. And that's actually a subtle way to look for some signs of neglect. The back of the brain is vision. And then you have your at the base of your brain down there is the cerebellum. And the cerebellum is involved in coordination. So the first thing you do when you drink alcohol is you knock out your cerebellum. So when people talk about staggering around like a drunk or slurring your speech when you're intoxicated, that's because the cerebellum isn't working right. And then the temporal lobe. The temporal lobe is more complicated than just memory, but one of the major things that it is involved in is memory. So with things like Alzheimer's disease, your temporal lobe is what's involved in being injured early on, and affects your short-term memory. So this guy is an amazing guy in neuroscience history. This is Wilder Penfield, and he was a neurosurgeon that trained at Columbia, which is where I went to medical school. Go Columbia! But he actually made his name because he went on and founded the Montreal Neurological Institute and became one of the foremost experts in brain surgery and brain in general. He actually pioneered a million things, some of which epilepsy surgery. And this is actually Dr. Penfield doing surgery. And what he what he's most famous for to me, and I think in general for a neurologist, is he did this amazing work where he would have people in surgery. And so he would actually ask you about your seizures. And he'd say, tell me what happens when you have your seizure. What's the first sensation you have? And you'd say, people would often tell him they smelled something funny, or they tasted something funny, or they felt a funny sensation in their arm. He would wake them up during surgery and had this little electrical pen that he would activate parts of the brain. And when he found when you said, yes, that's what it feels like when my seizure starts, he'd lop that part out and treat the seizures. And it was actually very effective, although we've fine-tuned the technique a little bit since then. But what he did was, as he did that over and over again, he actually developed a map of the brain. And so there's what we call this homunculus, this map of the brain that we all have in our brain. And so you can see this is the frontal lobe that I talked about, which really would be like back there. But the frontal lobe, and this is the motor area and the sensory area. And when you look up here, you can actually see in all of us, we have a very similar map of where things are located. And that sort of point out the areas that have the most sensation and fine motor movement, your mouth, your face, your hands, those take up a disproportionately large part of your brain. And so when we are looking for brain dysfunction, often the major places we're going to be thinking about and looking at are going to be the arm and hand and face for that exact reason. It's hard to have a blood flow issue to the brain and not affect the arm or the hand and the face. Another thing that's just worth to remember, which is your brain is flip-flopped, right? The right side of the brain controls the left side of the body, and the left side controls the right side of the body. Not quite so important in symptoms management or recognition, but just something to recognize in general with the brain, that everything is on the opposite side. But as a left-hander, I have to then remind everybody who's right-handed that if the right side of the brain controls the left side of the body, then as a left-hander, I'm one of the few people in my right mind. There's this notion, right, that your left side, left hemispheric people and right hemispheric people, that the left side of the brain is your analytic, biological sciences part of your brain, and the right side's more of the freewheeling artistic side. And there's probably some truth to that. The right side of the brain definitely with spatial connection and where things are in space. The left side, though, in particular, is really, really critical for most of us when it comes to language. And so left hemispheric strokes can be much more dangerous and devastating to someone's quality of life than a right hemispheric stroke because language is there. And so language is kind of an interesting animal. So in the left side of the brain, you hear information. Someone's talking to you, I'm talking to you. You're hearing me in your temporal lobe in an area called Wernicke's area, named after Karl Wernicke, a German neurologist. And that's where you comprehend what I'm saying. So your Wernicke areas right now are firing off like crazy. And then when you decide you want to say something, I'm going to tell that Teeple something, then it goes through this little arcuate fasciculus. This is a pathway to Broca's area. And Broca's area is what allows you then to be able to actually articulate what you want to say. So injury to Wernicke's area, what you see actually is people who, they'll blab away. They can say all kinds of stuff. Their Broca's area is fine, but there's not much content to the words that they're saying. Blue, potato, pink, onion, and they can't, and they'll smile and they'll talk just nonsense. Whereas someone who has a Broca's area injury, they can hear everything and they can understand it, but they can't get any of the words out. Very, very frustrating thing to have happen. These patients really, they can't understand. It's really hard. And so they may even say sometimes, they'll walk in the room and they'll say, hi, and they'll smile at you because they can do all those nonverbal things. And then you ask them to do something like, stick out your tongue, show me 2 fingers, do something that shows me you understand me. They can't do it.
For somebody like that, do they understand written
Usually they do not.
So
Usually they don't.
talk to them and they don't understand. You
Right.
Write it down, they can understand.
They won't understand. They will not understand you that either.
Either.
Nope. Now, a lot of these can be gray zones. So I would point out that that's a pure Wernicke stroke. Sometimes you have a little bit of both. So they can understand some things, but not other things. They can say some things and not other things. So often there's a combination of the two. So, okay, so that's our neuroanatomy. So with that neuroanatomy in mind, let's talk about then what are the signs and symptoms of stroke. I'll reaffirm, one of the things I love about the brain in general, right? I mean, the brain is just the most fascinating organ in the body. That's what drove me to be a neurologist and to study it for my entire life. And the brain does everything. I mean, really who we are and what we are is neurological, is driven by brain function. So I would point out anything can be the signs and symptoms of a stroke. These are far and away the most common things that we see, but anything our brain does can be a symptom of a stroke, and that makes it particularly challenging sometimes. So what are the big signs? What are the things really to be paying attention for that we would jump on or try and treat? And I think that the best thing to sort of use is this nice acronym, which is expanded. We used to just teach FAST, but now this be fast, I think, is a really good one to expand to. And you can see all these things that it is. So let's take each one individually. So balance, sudden loss of balance. So the next thing I'd point out is for all stroke symptoms, they should be sudden onset, right? And all of these things we talked about, whether it's a blocked artery or a ruptured artery, those things are they 1 second they're not there, and the next second, boom, they're there. So these should be generally sudden onset symptoms, not something that's gradually come on over the course of a week or days, typically. So sudden loss of balance. And so that typically would suggest to me that there's something going on with that cerebellum in the back of the brain, and people cannot suddenly be unable to walk, control their body. One of the things that we do often when we test for this, so maybe you've had this happen, is we do this finger to nose test. And what are we looking for? What the cerebellum does, okay, really is it coordinates your movement. So if I want to move, if I want to put out my arm, I'm trying to be on screen a little bit. If I want to put out my arm, I'm coordinating my deltoid, my lats, my biceps, my triceps, all these different muscles. And that actually is a complicated thing to do. And it's involved in keeping your trunk stable and moving your legs where they need to go. And so when someone has a stroke of their cerebellum, what you'll see is when they try to do the finger to nose, their muscles just don't work right. They don't coordinate together. So they overshoot. I'm trying to, but I can't get it to where it needs to go. And that's because that motor map that cerebellum is typically making doesn't work. We often will do something called a heel to shin. We'll have people take their heel and go up and down. And that's the same thing we're looking for is people who can't do it. They're going side to side because they can't coordinate the muscles. So sudden onset of balance. One of the things that can happen with this is you can get really dizzy. So dizziness and loss of balance can also be a sign of a stroke. I'd point out more often dizziness is an inner ear phenomena. Vertigo is a symptom of the brain, but also of the inner ear, and that's more commonly what causes that. But often, if it's the first time it's happened, we evaluate you for a stroke as well. Vision loss. So vision loss is one that probably many of us think about when it comes to stroke. And so vision is in the back of the brain, so the primary vision area. And so what can happen if you have vision loss that's from a stroke is if this is what normal vision looks like, you'll lose vision on one side in both eyes. And I'll tell you, this is a tough one because when it comes from your brain, part of what ends up happening many times in patients is it's associated with lack of recognition of a problem. Patients I see this is probably the most common symptom from a stroke I see, and where no one's complaining. Someone gets brought in and it's not right. They're bumping into stuff. I can't quite figure out what's wrong. And you test them and everything looks great. No one's complaining about vision loss. And you test their vision and boom, you realize there's a whole area that they can't see. So this can be subtle. Sometimes what we catch these when people who have car accidents because they can't see one side. And this is a tough stroke symptom because this is one of the few, I'd say, stroke symptoms that really make it impossible to drive a car safely. If you can't see the road on both sides and see people coming at you, then it is not safe to drive. The other thing that we'll see with a stroke is a stroke of the actual eye itself, the retina. And this is what it'll look like. Here it goes. You see that? And you notice how it comes down like a curtain coming down. And so what you can get is you can get lack of blood flow to the actual retina itself. And what you have in the retina is an artery that comes out and it sort of goes up and down. So when you lose vision because of a blood clot there, it comes down like a curtain or up like a curtain. And it's painless. And it typically, often, it can be permanent, but this is actually a classic TIA symptom where you have vision goes out, it's out, and you think, I can't see. That's so weird. It doesn't hurt. I don't notice anything. And then boom, it comes back. And then what happens to everybody? They think, I'm fine. I don't feel any pain. I'm fine. I'm not going to do anything about it. And then they don't do anything about it. And then a week later, a big stroke happens. So this is one of those things where if someone loses vision in one eye, painless, sudden loss of vision in one eye, even if it's for 20, 30 seconds and comes back, they need to get seen by somebody. And usually the big fear is the carotid artery. The artery that supplies your eyeball comes off of your carotid. And so that's usually the place that we look at, although I've seen it come from other causes of stroke as well. So down like a curtain. The next one, facial weakness. And so I would point out what side of this guy's face is weak. Yeah, good. Okay. Often people get kind of mixed up. And so, and I guess it's kind of hard to see, but you see his nice dimple on this side and just no dimple there. You can kind of way more teeth on this side and less teeth on this side. So his left, he's got a left facial droop. Now, how about this guy? Who thinks this guy's having a stroke? What's that?
You already had it.
Yeah. Okay. Good. And so this one is actually interesting. So this guy's not having a stroke. And if you showed me this guy in the ER, which happens actually on a somewhat regular basis, I could walk in 2 seconds and look like a superstar, even though I'm not, and say, it's not a stroke, you're fine. This guy has a Bell's palsy. Okay. And the way I know it is so he's clearly got a right facial droop. And you can see his eye is droopy on this side, which would be unusual for a stroke. But what I see the most is I can see his wrinkles in his forehead there. He's lifting up his eyebrow here, but his eyebrow is paralyzed on the right side. And so when the whole side of the face is involved, that's not a stroke. That's a Bell's palsy. And so going back to this guy, see, oh yeah, there you go. So, and so this guy, and I wish I couldn't find one where they're lifting their eyebrows up, but if he could lift both his eyebrows up. And the issue is in your brain, your eyebrows are innervated by both sides of your brain. So if you have a stroke on one side, the lower face gets weak, but the upper face, it can be innervated still by the other side of the brain that's working just fine. But everything below the eye is by the opposite side of the brain. So just the lower face will be weak in a stroke. And there's that. And then, and so asking someone to smile, important part of a stroke assessment, right? Smile, count the teeth, look at that, and just going back one more time, looking at that, this fold there, looking at that dimple on both sides. That's the key part of looking for facial weakness in a stroke. The next one is arm weakness, right? So having someone stick out their arm, and often I'll have them actually lift up their hands. So they're holding their hands up like they're holding up a bowl of soup, and have them close their eyes. And so what you see in this lady is that she's holding her hands out and one hand's going down. That's fine. But the other thing you can do that's actually a little bit more sensitive is close their eyes. And what you might see is that they're turning their hand over like that. And that's a subtle sign of weakness on the hand that's pronating. This is supination and this is pronation. This is called a pronator drift. And that's a sign of weakness. Why do we care so much about the face and the arm? Now you guys know, right? The homunculus, huge part of your brain, is involved in face and arm and hand innervation. So when you have a stroke, those are going to be the major areas that are going to be affected. Speech. And so the two things we look for are going to be slurred speech and then aphasia. And so slurred speech, right, that's due to the weakness of the muscles. The muscles don't work, and if you can't work the muscles, you don't enunciate your speech very well, and it's like it's a mouthful of marbles, and so you slur your speech, and that could be because the tongue is weak, the lips are weak, or often the palate in the back of your throat, which you use to speak with, is also weak, and that can give you like a nasal sound to your voice as well. So any type of, and what do you do? I mean, usually I'll have someone, just repeat a sentence for me. Any sentence you want. No ifs, ands, or buts. You can't teach an old dog new tricks. Today is a sunny day. Something. Do they say it clearly or not? And then the other thing with speech is aphasia. And aphasia is what we talked about when you knock out part of that language circuitry. Aphasia is just the term we use for inability to talk. The language circuitry doesn't work. So it's not slurring of your speech. It's that either you can't comprehend what people are telling you, or you can't get the words out. And so when you assess someone's speech when they're having a stroke, you want to assess, can they comprehend what you're asking? And often I'll ask someone, show me two fingers, show me that you understand me. And then again, having them repeat a sentence. Can they say what they wanted to say? One of the impaired expression things people will say, it's a classic thing that they say when they're having a stroke is, doc, I knew what I wanted to say, but it just wouldn't come out right. I spoke and it was gobbledygook. It was not at all what I intended to say. And that's different than I said the words and they were just very thick and unintelligible. It was like I said the wrong words. Or my husband or my wife looked at me like I was crazy, that I was saying nonsense. Those are things that make me think about aphasia and part of that circuitry, that Broca's and Wernicke's area being involved. So I'll ask them to repeat a sentence. Is it clear? Did they understand what I asked them to do? Ask them to do something simple like show me two fingers. Can they follow a spoken command? And then ask them, name a couple of objects. Hold up a pencil. What's this? People, you'll be shocked. I mean, with a stroke, they can't name obvious things. And so that's how you assess symptoms, those speech symptoms. Now, there are certainly one thing I'd point out. So that's be fast. Okay, we're not done with it yet, but I want to point out to you, did I say anything about pain just now? I didn't. And I want this to be really clear to everybody, which is strokes don't hurt. Okay, some do, but most really don't, right? The vast majority. What is the biggest issue I see with my stroke patients? It's that they don't come to the hospital fast enough. I woke up, my arm wasn't working at all, but I felt okay, so I just went back to bed. And I was like, what? And it's because it doesn't hurt, right? Chest pain hurts. Everyone gets into the hospital as quick as they can. But a stroke, and I can imagine I would be in the same boat, right? It's just, there's no pain. And you think, I must be okay. I feel everything else feels fine. I think I'll be all right. And so don't let someone you care about blow it off. If they're having symptoms, make them go. The other part of it is a lot of strokes are associated with that neglect. You just don't recognize what you can't do. When the organ in charge of knowing what's going on is the one that's not working right, you don't always understand what's going on and make the best decisions. And that happens a lot, frustratingly, with strokes. Other things that we can see, so that sudden confusion. Again, and I guess I would point out, sudden confusion as a stroke symptom really to me is a speech issue. Suddenly you can't understand, you can't talk. And, often that's really just sort of like, hey, it's just really confused. Something's not right. He's moving everything, but I can't figure out why he's not doing what I asked him to do or understanding me. There is another entity that's just kind of an interesting thing to be aware of. It's this entity called transient global amnesia. And transient global amnesia is rarely, and I would point out super rarely, a stroke symptom. But by and large, it's actually a fairly benign thing, but it's scary. And that is when people have this sudden inability to make new memories. So they just 1 second they're fine, and the next second they forget, what they're doing. Why are we in the car? We're in the car because you wanted to go to the mall. Okay. why are we in the car? And they'll just repeat the same questions over and over again. They can talk, they can move everything just fine, but it's this sort of sudden inability to make new memories, repeating the same questions over and over again. All those patients I tend to evaluate for stroke. And I would say, 1 in 20 do I ever find a stroke in. And by and large, it's just something that passes, scary as heck, and it's something we see a lot. That is certainly a reason to come and get evaluated in the ER. And then sudden lower extremity weakness. So it is possible to have a stroke that affects just the leg. So if the leg were to go suddenly weak and it's just one side, that could be a stroke. It is an uncommon type of stroke to have, but it certainly does happen. So don't blow that off either. I don't think anybody would.
What else might cause that?
What else could cause that? Spinal cord issues usually are a more common cause for something like that. And then lastly, headache can be a sign of a stroke. So certainly sudden onset, worst headache of your life, that is a sign of a subarachnoid hemorrhage. That is someone that needs to get evaluated. That's usually something that's readily visible on a CAT scan. We can evaluate that very quickly. But keep in mind, that is a shockingly small percentage of strokes that happen. But certainly that is one to keep in mind. So be fast. Okay, those are your stroke symptoms. Now, we didn't talk about T. Time, right? And so, okay, for emphasis. So time is a critical element of this, right? So when that clot is there in the brain, and that's the 89%, 90% of strokes, the ticker is going. And there's this famous study done by a neurologist at UCLA where he calculated on an average size stroke. If we look at how many brain cells are lost and compare that to just how many we lose in life, he calculated that we lose about 32,000 brain cells a second, and about 2 million brain cells a minute, 120 million per hour, and 1.2 billion brain cells per stroke. And that advances our brain age by an average of 36 years per moderate size stroke. Now, again, not all strokes are moderate size. But the key here is every minute we're losing opportunity to treat. And so time is really of the essence. Time is brain. And so what are the treatments for stroke? So the first line treatment that we give is clot buster, right? We give clot buster to break up the clot that's blocking the artery that's causing the inadequate oxygenation of the brain.
And you don't necessarily know where that is, right?
Right. Absolutely.
Just go for it.
That's right. And we can do it only up to 4.5 hours after onset. Beyond that, the benefit and risk become, the risk outweighs the benefit. So time is absolutely critical, but I'd point out that the effectiveness of clot buster is better at 1 hour than at 2 hours, and better at 2 hours than 3 hours, and better at 3 hours than 4.5 hours. So the sooner we get it, the better, the more effective it can be. And this is an interesting drug. It has not been without some element of controversy over the years since 1995, since it was FDA approved. And the issue is it helps. So if you give TPA to 100 stroke patients, the ones in dark green are going to walk away like nothing happened. The ones in light green are better. The ones that are white had no benefit. The ones in red are worse, and the one in dark red may be dead. And so it is a drug that has risk associated with it. And as you were alluding to, I think earlier, when we're treating stroke, we often don't even know 100%. Sometimes we do, but sometimes we don't know 100% that it's a stroke. That we need to make this decision as fast as we possibly can, and we're treating with a drug that has some risk with it. And so we're all, as a general rule, really cautious and careful about treating with this drug. That being said, stroke is the biggest cause of long-term disability, and if we can help this many people by treating, it is a unanimous we should treat and be aggressive with treating. But we're all also aware that there's some risk with this drug, and we're careful about it. Now, I come back to time is of the essence. So a question that got posed to me a while ago, and I think it's a reasonable question for any person to have, which is, well, if it's so important to do this fast, why not do it in the ambulance or even treat people at home? And the answer to that question is strokes, you can't tell the difference. These two patients could be having exactly the same symptoms, okay? But this guy here, this guy's having hemorrhage in his brain, okay? And this guy has a blood clot somewhere that we can't see. If I give this guy TPA, what do I do to that hemorrhage? I make it real big. I probably kill him. Whereas this guy, I could save him. And so the key is you need to be someplace where we can evaluate you, that you need at least a CT scan of the head to make sure there's not a hemorrhage, to make sure there isn't a risk there that we can treat with IV TPA. And I just sort of throw out there, one of the cool things that exists, although we don't have one in Tucson, are these mobile stroke units, where they've actually got a giant ambulance that has an actual CAT scan in the ambulance. So you get loaded up in the ambulance and get scanned, and then the neurologist actually, I did residency with this guy. They can treat you right there on the spot.
That's a cat van.
What's that?
A cat van.
That's a good one. They're called mobile stroke units everywhere, but a cat van is good, or a stroke van, stroke cat van, cat stroke van. But I'll point out, this is tough, right? Like, so say we had a stroke van in Tucson, where do you put it? Do you put it down south? Do you put it in the foothills? Do you put it northwest? I mean, you need 5 of them around here to be in all parts of town. Who's going to pay for that? I mean, this is, millions of dollars to have this thing. And then to run it, the one they have at Barrow, I'm trying to remember how much they said it costs per month, because it's so hot. And in the summertime, they actually just pay for the gas to cool the thing, cost, tens, if not more, thousands of dollars to keep it running. So these are big issues. And then on top of that, the treatment is expensive. Who pays for the treatment? Is it the hospital? It gets really, really complicated. But, these are the ideas that we've trying to come up with to find faster ways to treat people with TPA, because no doubt the faster we can do it, the more effective it is. The next thing here is, and this has been the one of the more exciting things that we've seen in stroke care in my time, is the interventional treatment. And so the interventional treatment that we use is something called a thrombectomy. And so that's just, right, that's fancy for thrombus is a clot, and ectomy is removal. Thrombectomy is removal of a clot. And so you can see this patient here, this is their carotid artery, and it comes up and then it stops abruptly. There's a clot right where that red arrow is. And so this guy, so what they do is they have this catheter that goes in usually through the groin, through the iliac artery, and goes up into the brain. You can actually thread it right up into the brain, like you're going to do a coronary, a heart angiogram, but instead go up into the carotid and into the vessels of the brain. And it's kind of hilarious, okay? Because what they do is they have this catheter, and it's hooked up to a vacuum cleaner. That's what I call it. And they just set the catheter up there and then turn on the vacuum cleaner, let it run for a little while, and then turn it off. And they look and suck the clot out. I have pictures. I didn't put it in this talk. I have pictures of clots that they suck out, and they're just in the shape of your blood vessel. And I mean, and it's amazing. I mean, you get results like this. This is all blood vessel. This is all that area that wasn't getting supplied. That's getting supplied now. And this is not everybody, okay? It's in the subset of patients who have a large vessel that's blocked off. Okay, if it's a little micro vessel, we don't have catheters small enough to get into micro vessels. But when there's a big clot there, this is a super duper effective treatment, and one that we're doing now 24/7, any time we can, because this is I've seen people who have come in with strokes that have put them into a nursing home and a feeding tube and a wheelchair for the rest of their life, walk out of the hospital 4 days later. It is amazing.
How can that be if, like, 24 hours later, all those cells have died?
That's exactly right. So they haven't. So you got to do this fast enough before the cells die. And so it's not available for everybody. We do it up to 24 hours. And it's really interesting. I underline some strokes. and you make a really good question that segues into a point, which is, if all of us had the same clot in our brain, this clot, we would each have a stroke at a slightly different rate. That data from the guy at UCLA, it made it sound like that's how it is in everybody's brain. But some patients, some people have really great collateral flow from other blood vessels, and their brain can survive 24 hours. And some people, they just don't. And some of it's just how our brains develop. And so you put the same clot in different people. Some people might last 24 hours. Some people might last 16 hours. Some people might last 1 hour. And, trying to pick the patients who have viable brain tissue left to be able to save is one of the parts of that, how we evaluate and decide whether or not this is something that would make sense and be helpful. So it really depends on the patient and how your anatomy is. But I'd point out it is incredibly effective. And so this is above and beyond what the clot buster does. So these are patients who got clot buster, and then if they got thrombectomy too, there's a huge number more patients that can be treated and actually much less likely to cause harm. You can cause harm, but it's much less likely. So to review, blood clot, this ischemic stroke is the most common type of stroke that we see. That's a blood clot that blocks an artery to the brain. And the most common things that you're going to see are going to be balance issues, vision loss, facial weakness, lower face, arm weakness, speech problems. And when that happens, we want to know what time it is and get to the hospital. An important factor to sort of point out too is getting to the ER is the most important thing. Whatever's easiest to get to the ER with, do it. But I would point out paramedics and the EMS, they are the best way to get in. They come in, they'll see you, they call ahead to the ER, they know the closest stroke center to get to. They'll call the ER and say, we got a stroke coming in 3 minutes. Everybody knows to line the way to the CAT scan and to get things moving as fast as they can. Whereas when you come in just from your own vehicle, there's a big line. You've got a frazzled triage nurse that's trying to do his or her best with 1 million people who think they need to be seen right this very second, and that can slow things down a little bit. So paramedics, the best way to come in my opinion, if you're having stroke symptoms. But if for some reason you don't want to use paramedics, getting in the ER is the most important thing to do. And then, and just as a reminder, when it comes to stroke, time is brain. Every 10 minutes you save brain cells. Every hour you save, every minute you save, every second you save. And that's it, guys.
So,
Thank you.
Dr. Teeple. Hold on just a second. Sorry about that. I just removed you instead of your screen here. Okay, so I had a couple of questions come in online that I wanted to ask you, and I know your in-person audience might have a couple of questions as well. One of the questions that came in was asking again about that transient global amnesia. And I'm pretty sure is that a risk factor for an ischemic or hemorrhagic CVA or a TIA at all?
Yeah.
Will you repeat the question?
So is transient global amnesia a risk factor for a stroke? And so the answer is, we used to think, when I was in training, we were taught that was indeed a risk factor for stroke. It looks like, subsequently looking at all the data, it's not a risk factor for stroke. The other thing that people worry about often when it comes to memory, is it a risk factor for dementia? And the answer is, it's not a risk factor for dementia either. So from my end, not a risk factor for stroke, not a risk factor for dementia. But I think that rarely a stroke can manifest like a transient global amnesia. So I usually, especially the first time it ever happens, I evaluate you with an MRI to look for a stroke. Yes,
Great.
question.
You saw me at TMC with the TGA.
I did. Okay.
5 years ago.
All right. You're doing great. Okay. Good to see you. I'm glad you remember. Okay, next question.
So I have another question, and that is, how long do you wait to see if the first line of treatment works before you would move on to the next treatment?
And so I guess that would be a question about, if you give the clot buster, how long do you wait to think about doing that thrombectomy? And I would tell you that if there's a large vessel occlusion, I would treat with TPA. And as I'm treating with TPA, I'm calling the cath lab saying, get in here now. There's a large vessel occlusion. So, and the worst thing that could happen would be you give the TPA, and while the cath lab team is coming in, the symptoms completely go away. In which case they say, sorry, false alarm. Or you do the cath, and when they squirt a little bit of dye up to look at the blockage is gone. Great, we stop right there, and no one does anything else. But from my end, I would. That's an approach that's changed over time. Okay, so in years past, we might wait a little while, but what's become clear now is that if there's a large vessel occlusion, you should treat with clot buster, and at the same time, you should do a thrombectomy. And the patients who have both do the best. So we do both.
Okay, and I've got one more question that came in, and that was about the mRNA vaccine. Would there be any chance that scientists are working on developing anything to prevent strokes? Somebody has heard about a company that is looking at that for cardiovascular disease.
And so, one, I hate cardiologists. We're always behind them. They're doing stenting and all kinds of cool stuff. But so I'm not aware of anything that we're doing on that end. And I would point out, stroke. One of the problems that we've had, stroke docs always look at cardiologists because there's a lot of similarities. But one of the issues that stroke medicine has had is that there's a lot of different things going on with a stroke. So a coronary artery disease and heart attacks tends to be one pathology by and large. In stroke, there are quite a few different pathologies and things that are going on causing stroke, making it hard to sort of have one, this is what's causing stroke. This is the vaccine we give to treat everything. So I don't know of anything that we're doing right now in stroke care. That may change.
Okay, thank you. Jennifer, you may have some questions in the audience there. And actually, I do have another one that just came in. Are there any signs or symptoms in advance of a stroke, days or weeks in advance, that somebody might want to be aware of? Right.
And so, the big ones would be the TIAs, right? The transient ischemic attacks. And it's a great question and worth it to sort of harp on, which is a TIA is going to be one of those stroke symptoms. Right, it's a clot that comes up, blocks an artery, and you have some deficit, vision loss, weakness in an arm, facial droop, speech problem, but it's brief and it goes away, and there's no pain associated with it. You feel fine. You just had this funny episode where you couldn't talk, or you couldn't see, or you couldn't move your arm right, and those are the things that I would say. Those are the things that you shouldn't ignore. Those are the things that you need to get checked out. And they're easy to ignore. I could see myself doing it. I understand when people do it, but you can't do it. You got to get them checked out.
Great. Thank you. Jennifer, are there any questions from the audience?
Yeah.
If you've had a TIA in the past and you are on a blood thinner, is it likely that you could have another one if you're very, very blood thinner?
Sure. So the question is, if you had a TIA in the past and you're taking a blood thinner, are you likely to have another TIA or stroke if you're good about taking your blood thinner? And the answer is more complicated than that. And so I would point out that it's thought that 8 out of every 10 strokes, so 80% of strokes are preventable. And prevention is a whole separate talk, which I'd be happy to give sometime. But prevention is your blood thinner. It's making sure that your blood pressure is well controlled, your cholesterol is well controlled, your diabetes is well controlled, you're getting regular exercise, you're eating a heart healthy diet. And if you're doing those things, the data says that 80% of the strokes that are out there are completely and totally preventable. So if you're doing those things and taking your blood thinner, absolutely, you can prevent it. And the hope would be that you wouldn't have another stroke or TIA. Other questions?
I was thought to have had a TIA through February to
Okay.
start off.
Okay.
Because I thought I stubbed my toe and hit my head real hard.
Okay.
But some of these things were coming up earlier
Okay.
that I noticed.
Okay.
But I had a lot of what you're rating here. I had just got everything.
Okay.
And so they did an MRI and it didn't show anything.
Okay.
But then a doctor talked with me and told me that inflammation and I can't remember it all, could contribute, stress could contribute to an MRA. It might not show up on an MRI.
Sure.
So is a scan, CAT scan more clearer?
So the question ultimately is a CAT scan more clear than maybe an MRI, and can you have symptoms that aren't necessarily visible? So as far as stroke goes and the brain goes, MRI is the best. A CAT scan is a little bit better at showing blood, maybe than an MRI, but you'd see it very well on an MRI too. But as far as strokes and brain injury, you see it better on an MRI than anything else. One. Number two, there are a lot of things that can mimic a stroke that aren't. I mean, stress can do weird stuff. Migraines are a classic. Seizures can actually mimic a stroke as well. So there are other things that can mimic a stroke that aren't a stroke, but you don't know unless you look. A hard one to answer perfectly, but then probably the answer is yes.
My daughter 2 years ago had a stroke,
Mm.
and she didn't get to the hospital right away. And now she doesn't remember from one minute to the next.
Mm-hmm.
Is there help for that?
Mm-hmm. So the question was, a patient has stroke, and the byproduct of the stroke is memory loss, and is there therapy for that? So the first thing I point out is strokes can do anything. So if you have a stroke that involves the part of your brain involving short-term memory, usually the temporal lobe, it can really have a big effect on short-term memory long-term. And the answer is yes. Cognitive therapy, usually done through a speech therapist, is the most useful type of treatment for that. It can get better, but how much better really varies on how big the stroke is and what she's able to do. It's a tough one. That's a tougher one. I point out that, people who have strokes, all strokes get better. But the question of how much better is the harder one to answer. And recovery can be slow over time. It usually takes months, but I would point out it can happen over years. But cognitive therapy with a speech therapist would be at the top of my list for things that she should be doing if she's not. Okay. Yeah. Where do I go next? Okay.
Is there any treatment for the COVID-19 short-term memory loss? First of all, I had severe virus in early January 20.
So the question is there any treatment for the COVID-19 memory loss that happened from the infection? And the answer is not that I'm aware of, beyond time and all the things that we know are good for memory and thinking in general, which would be keeping your brain as active as it can be, eating a heart healthy diet, controlling your risk factors for stroke, which also have an effect on memory and thinking and time. But as it stands now, that's probably the best advice I'd have for you, with the hope that it can and will get better, but probably more time than anything else. Yes. And so, right. So if you have a TIA, what does it mean? So the idea behind concern for TIA is that it implies there's some risk factor that needs to be addressed, whether it's a blood thinner or carotid stenosis that needs to be addressed, or a heart issue, or high blood pressure that's not being treated well, or diabetes that's out of control, or cholesterol that's out of control. So the idea is that all of those things should be addressed in the setting of what we think is a TIA. The issue of a blood thinner is this. I would point out that when it comes to coronary artery disease, heart attacks, the blood thinner is incredibly important. When it comes to strokes, it gets less important. It depends a little bit on the type of stroke and what's going on. But I'd point out in most of my patients, not everybody, but most, better control of their blood pressure, better control of their diabetes has 10 times the value to reducing the risk of stroke than the blood thinner. But there are some where that's absolutely not the case, where they need the blood thinner. So ultimately, the answer to that is you should be evaluated and have your risk factors assessed. That's really the important thing. And most of those patients walk away on some type of blood thinner, usually just a chewable baby aspirin, but sometimes stronger. Okay.
Dr. Teeple, I want to thank you so much for being here today and, experimenting. This is our new hybrid method, of course, so we're still working out all the kinks. So I appreciate you being here. Everyone, we do have our next talk will be next week on the effects of medication and what you need to know. That'll be on Wednesday, March 30th at 10 a.m. And thank you all for being here.
Thank you, guys.